afternoon. Thank you for joining us for the Transitioning Youth to Adult Healthcare Training and Resources webinar. This webinar will be presented by Dr. Rachel Kasky and Kathy Sanabria, Illinois Chapter American Academy of Pediatrics, Associate Executive Director. This is the first of a 5-part webinar series on adolescent health topics. Dr. Rachel Kasky and Ms. Sanabria have no financial relationships to disclose prior to presenting. Funding for this webinar series is provided in part by a grant to the ICAP from the Illinois Department of Public Health Adolescent Health Program. The Illinois Chapter American Academy of Pediatrics is accredited by the Illinois State Medical Society to provide continuing medical education for physicians, and ICAP is also, so for each live webinar, a maximum of 1 AMA PRA Category 1 credit is offered for physicians to claim. In terms of CE credit information, the Illinois Department of Human Services Division of Developmental Disabilities has approved this live webinar for 1 continuing education hour for today, and the following licensed professionals are able to claim them. Qualified intellectual disability professionals may apply the same hours of continuing education units earned from this webinar towards their earned from this webinar. Yeah. The webinar series planning group includes Dr. Sarah Parvinian, Dr. Kasky, Ms. Sanabria, Olivia Phillips, and the CME reviewers were Dr. Karen Judy and Dr. Leichner. And none of the planning group or CME application reviewers have financial disclosures. This webinar is being recorded and will be made available immediately following the webinar at illinoisaap.org. For more information, please contact myself, Olivia, at ophillips@illinoisaap.com or by phone. During this webinar, participants are muted, and so for questions, any questions that you may have, please type them into the chat box, and we'll save about 10 minutes at the end of the webinar, at the end of the presentation to address those. In terms of evaluation, at the conclusion of the webinar, attendees will be emailed a link to complete an online evaluation. Once the evaluation is submitted, I'll send participants a certificate of participation for your records, and this will occur about the first week of February. For our presenters today, Dr. Kasky, she's currently an associate professor at the University of Illinois at Chicago College of Medicine and School of Public Health, and also is the chief of the Division of Academic General Internal Medicine and Geriatrics at UIC. She's board certified in both pediatrics and internal medicine and is a primary care provider for all ages. Dr. Kasky is a champion for transitioning youth to adult healthcare, as well as Ms. Sanabria. Currently, she is ICAP's Associate Executive Director and has over 25 years of experience working on medical home initiatives. Kathy emphasizes the importance of successful transition, and she is also a parent of a young adult with special health care needs who is also in the process of transitioning to adult health care. The audience that we currently have today on the webinar is a mixed audience of physicians, nurses, allied health professionals, and other health professionals such as office managers and school administrators. And now I would like to turn the presentation over to Dr. Kasky, as she will lead us in the discussion.
Thank you, Olivia. All right. So as we go through the presentation here, myself as well as Kathy are going to be presenting. We're going to start with really talking about what is transition of care, why it matters, why it's important to us. We'll talk a little bit about billing and coding strategies, though I realize that's a complex topic, but we'll give you a little framework for that. And then transition towards the end to the ICAP transition course for pediatric providers, which is really a phenomenal course that's been developed by an interprofessional group of experts on this topic that is available for CME as well as MOC credit for those who are interested. Okay, so what is transition? And I know for many on the phone, this is a topic that you know about, you're familiar with. But for those who are less familiar, we really think of it as a purposeful and planned movement, and that's important. Not hopefully not an afterthought or a missed opportunity, but really something that is intentional and planned over time. It's the process of moving from a child-centered, or perhaps better thought of as family-centered care, to adult-oriented care. And not that adult-oriented care does not include family members as part of the team, but the focus tends to be more on the adult patient and less on the caregivers. And this is important for everyone, all of us. This is important for youth with or without chronic medical conditions, though we do pay special attention to our youth with chronic medical conditions, as their timing and efficiency of their transition may be more important, or at least could have more adverse outcomes if it's not done well. So why is it important to transition? So we all grow and develop, of course. All of our patients grow and develop regardless of their health status, and we need age-appropriate care. And that is important, again, regardless of health status or chronic medical conditions. Pediatricians, as we know, and family practitioners who care for children are specialists in the care of youth and of people for whom others are typically the primary decision makers. And these providers may not be as comfortable managing adult conditions, for example, coronary artery disease, prostate disease, hypertension, the list goes on. And for good reason, this is outside of their training purview. And we often forget that many of our youth that have substantial special health care needs are not immune from adult disease or adult focused health needs, right? And so it's really important, even though they may always have someone else making a lot of their decisions or require a lot of support for their care needs, they still are not immune from these adult disorders. And so the transition is important. So when is the natural transition times? And again, there's no right answer to this. Often it's going to happen sometime around the age of majority, 18 to that 21, early 20s timeframe. Again, that is not absolute. It can happen at different ages for different individuals. It could happen at a time of decision maker status. So if the patient becomes the decision maker or loses that capacity. Often, particularly for our more healthy patients, going off to college or starting a job after graduation from high school or completing school is often a common time where this happens. Changes in benefits or entitlements is really also a common time. Aging off Medicaid, for example. Pregnancy is a time for women where this can change and that they then take on more of their own decision-making capacity. And ideally should not be during a time of medical crisis. And that probably goes without saying, but what we don't want it to be is a young adult who is in the time of a medical crisis and then realizing care needs to be transitioned, and there's a flurry of activity trying to get the young adult transitioned. So ideally, this happens over the course of months, if not many years. So everyone needs a transition of care. As I mentioned earlier, the process and timing is more critical for our youth with chronic disease or special health care needs. There's no one approach, and there's no universal approach to this. A national data would suggest that only 17% of youth with special health care needs and 14% of all youth report transition planning. And this is self-reported by caregivers or youth themselves. But this is if they recall having any conversations or explicit activities around the process of transitioning their care toward adult-focused care. So these numbers are low. In an ideal world, we would love 100%. We will probably never get 100%, but this is certainly a very low number of youth that report any recollection of transition planning. And the interesting thing is, from the pediatric perspective, we have a real epidemiologic shift in the patients we're caring for. Over the last 15, if not 20 years, we've had a substantial change in the number of youth with chronic disease. And it has really changed the practice of pediatrics. We now have about 20% of U.S. children with a special health care need. We know among households with children with a special healthcare need, or excuse me, among all households with children under 18, nearly a quarter, 23%, include at least one child with a special healthcare need. And we have a far more adults than children with many chronic diseases that were not diseases that tended to live to adulthood in generations past. So we now have more adults with sickle cell disease, cystic fibrosis, and congenital heart disease than we have children with those diseases. And of course, this makes sense, right? As our research and technology and advancements progress, the longevity of these diseases progress with it. And as children age into adulthood, that the population in adulthood continues to expand, but the population in childhood is very static. So this makes sense. The challenge, though, is that the training of providers has not kept up with this. And so our providers going into adult focused care are not necessarily getting more training on cystic fibrosis, sickle cell disease, congenital heart disease, and so forth, which is an important gap in exposure and comfort level. So challenges with transition. Who will accept my patient? And this is a common challenge, and we've all been there. I can't find an internist who feels comfortable with caring for an adult with spina bifida, or they have a full panel, or I can't find someone in this community, or whatever it might be. There's a lot of providers that struggle to find the right match for their patients, whether it's based on geography, specific disease, or perhaps the family has a preference in terms of whether their provider is male or female, and those sorts of things. So this is a real challenge. I imagine it's a greater challenge in certain geographic areas, but I will tell you it's even a challenge in the middle of Chicago, where there are no lack of medical centers and providers. We still struggle to find the right match for patients. And a lot of this is just either lack of good networking around finding the right internist, or fear on the internist side that they don't feel comfortable taking care of a patient with cystic fibrosis. For example, when I was in training, there were no adults with CF. Well, that may be the case, but we're going to have to get past that response, because we know not knowing anything about a disease is not an excuse in healthcare. It's completely normal. And that this is exactly the point of healthcare, right? We grow and advance. Nobody knew anything about HIV prior to the 80s, or really we could even argue into the 90s, before we had a clear understanding of the disease progression and treatment. Certainly managing complications of pediatric cancer treatment was unknown for many years, until we had children surviving and living to develop complications. When I was in medical school, human papillomavirus was not the known cause of cervical cancer, head and neck cancers, and so forth. So this is all very new information. And certainly just because that wasn't the case when I was in training doesn't excuse me from vaccinating. Renal replacement therapy, the list goes on. So not knowing something is not an excuse, but we need to support providers who feel very uncomfortable managing a patient with a disease that they just don't know much about. So what do patients need? Of course, and really this is patients and families. They need education and support. They need reassurance, right? That it's going to be okay. We're going to figure out a good home for the patient and or the family as a unit. They need referral and access to adult-based services, and an understanding that pediatric services will end. And this is interesting because this can be hard on both sides, by the pediatric provider as well as by the family, because this has been a long, often very important relationship, and ending those relationships is difficult. It was particularly emotionally difficult. Support as patients perhaps become decision makers. Accurate information about insurance and entitlements, and I know this can get very tricky, and there's a lot of misinformation out there, and so this is where we really need to point families in the right direction. And then what to expect, because we know culture and practice setup is very different in adult-focused practice compared to a pediatric practice. And then what do families need? They need assurance of a commitment to the patient, assurance of communication, acknowledgement of their work in the past, and their current anxiety over that transition process, as I mentioned. And then, of course, they need trust in the receiving physician. And that is a difficult one because, of course, trust is developed over time. So that's nothing that can happen just, on the spot necessarily, but perhaps a reassurance that trust will develop over time. And if it's not the right fit, that their pediatric provider could help them find someone else if the initial plan does not work out. And what do pediatricians need? And we all need confidence that our patients will be well cared for, of course, hopefully develop relationships with individuals that can accept patients, and then develop a network of trust where they can contact us if there's questions. That it's open, and that even after the patient has transitioned, if there's support needed or if the internist has questions, that they could call and that we would always be, of course, happy to help them. And hopefully a sense of pride that our patients are growing and moving on, which is great. Providers for adult-focused care, of course, may need disease-specific information, depending on the disease or the circumstances. They need patient and family-specific information, particularly in situations where caregivers are very involved and or perhaps decision-makers for the patient. Hopefully an attitude of welcoming family. And resources for social services beyond what they already use, because of course, social service needs could be different, particularly for our children and families with special healthcare needs when it comes to guardianship and these other things that may not be common in their practice. A referral network for subspecialists, luckily, is a very, very common entity among most providers for adults, so that usually is already well established. So I'm going to talk just a little bit about transition payment and acknowledge that this is a complicated topic. I suspect most of you who bill for medical services like me, billing is not your favorite topic. And so we'll talk a little bit about the different codes. I'll give you a framework. And the most important take home from this is if you believe there's opportunities to bill differently in your practice based on the care and transition services you provide, I strongly encourage you to get some expert help with that, whether you have a billing and coding department within your practice or medical center or so forth, because there's a lot of nuances and it really helps to work with someone who spends a lot of time looking at these codes. Like anything, of course, you have to use the codes properly and document. So patients with complex conditions, often we end up using already a higher intensity codes, perhaps a level 4 or 5 for newer established visits, which is probably common practice among most of you on the phone that bill for services. There's already an expectation of documented services for care and for care coordination, which we'll talk about. Phone calls and correspondence can count toward billable services, and bundled time in a visit or bill separately. And so this is interesting too. There are opportunities to bill for care coordination related services within 30 days of a in-person visit. So as mentioned, transition of care may occur over several visits, or it could be a dedicated appointment. So there could be a visit where we're not going to talk about the diabetes, we're not going to talk about these other things, we're just going to talk about transition, or more realistically, it's going to be something that comes up over time. And you're going to use all your usual components of your documentation and billing. So time-based billing, a number of transition of care codes are time-based. And there's 2 different ways this can happen. It could be time-based outside the visit or time-based during the visit. If it's during the visit, the care coordination must exceed half of the visit. For all of the codes we're looking at, it's only for physician time. And it is a little bit limiting. I would say it's very limiting from that perspective. That may change in the future, but for now it is only for documented physician time. As you probably expect, total time and how that time was used has to be documented in the note. And then using the right CPT and associated ICD codes, of course, is important for any billable service. And getting to know the insurers. There are differences, as you all know, there's differences by what payers will cover. Public, whether it's the traditional state Medicaid or the Medicaid MCOs, each can have their own plan when it comes to what codes they'll cover. So if we look at the non-face-to-face, these are some codes for services performed when the patient is not present. So this could be review of reports and labs, right? If the family drops off some reports that need to be looked at, perhaps you're spending time researching options or treatment for the patient outside of normal patient care, guardian provider discussions by phone, correspondence, so forth. And this can be reported once per every 30 days. It is not required, but it's recommended that there is some sort of a log for non-face-to-face time, mostly for use if audited. And again, there are some examples of this in our training, our transition training program, but this could be as simple as a quick Excel spreadsheet or just somewhere where there's some notation of the non-face-to-face time. It could absolutely be a note in the medical record, just a quick, a non-face-to-face encounter note where the time and what was done during that time is noted. The services can be either before or after the face-to-face. It just has to be within 30 days, before or after, and then these bills are submitted at the time of the face-to-face visit. So let's say there's some care coordination done a week prior. These codes would be used in addition to the traditional E&M codes when that patient comes in for the visit. The most common are the 99358 and 99359 that you see at the bottom there. And the specific use of these per CMS is the total duration of non-face-to-face time spent by a physician or other qualified health professional. I believe a nurse practitioner qualifies for this, on a given date, provided prolonged services, even if time is not continuous. So it's the added time. So it could be 3 different phone calls on 3 different days a week before the visit and so forth. These are time-based. So for example, 99358 is anywhere from 30 to 74 minutes. 75 and up is 99359 and so forth. And so the nuances of the time is something you would want to look up. And this is additive time. It can be all the different services added up either before or after the visit. Most people use these before the visit because you don't want to delay submission of your code for the visit afterwards, right? Most people want to get their billing done pretty rapidly after a visit. So most people are using these codes for services shortly before the visit. And again, they'd be submitted on the date of the face-to-face encounter. So that time clearly sort of, it's helping the work being done, and this non-face-to-face is helping make that face-to-face a better or more efficient encounter. Prolonged care services, and this is now face-to-face, and these are add-on services. They're reported in addition to your E&M codes if you're doing an established visit, level 3, level 4, level 5, whatever it might be. And this is if there's direct patient contact that is extended. And again, these are time-based, as you can see in that chart there, and they are added in addition to the traditional E&M codes for that visit. Some insurers will do reimbursement for non-face-to-face team conference. I've found this varies dramatically by payer. I personally have never used this code, so this is something I would look at because, and the need for documentation would have to be clear on this too. And I would always recommend just a note in the chart about the team conference, who was there and what was discussed. But this is an option for some payers. And of course, these are your preventive and return visit E&M codes. And again, the codes I mentioned could be used in addition to those, right? As you know, Medicaid in particular will not reimburse for both a preventive care exam and a focused medical service on the same day, although others will. So you can do a 25 modifier for many of the commercial payers, but you cannot for Medicaid. But that is something you could think about for particularly children with complex disorders who also need their well child. Those can be done. Some insurance companies allow you to do them both the same day. They do have to be very clearly documented as individual encounters, even if they're on the same note. But public insurance does not allow that. Medicaid and the Medicaid MCOs do not allow for that. This is just one example of Jenny, who's 23. You can see the issues listed there, most of which related to her underlying spina bifida. And this is just an example where a code 99358, which is a non-face-to-face prolonged service, could be done for care management and goal planning and such beforehand. And then when Jenny came in for clinic, this would then be added as part of the visit. And this is just one example. Again, you could, this extra services could be billed a few different ways. It could also be an extended clinic visit, right? In which case you'd use the 99354, 99355. So again, it's important to get to know the codes and the restrictions. There is a lot of information online. You can certainly do your own education. And what is good is because there's growing availability of these codes and growing interest in learning the billable services, I have found every year there's more and more stuff online about this. And there's some really helpful things. The American Academy of Pediatrics and the American Academy of Family Practitioners both have some really helpful web-based tips and guidelines, FAQs, that you can look at for billing transition of care. Consider just a uniform way to document your time spent, whether it's non-face-to-face or even face-to-face. Tracking sheet to document time spent in the services conducted during that time. Of course, not all codes are reimbursed by all payers, and many payers are not very facile with these codes. So I have had experiences of denials where, in fact, unfortunately, a lot of time was spent adjudicating with the insurance company because the folks on the insurance company side didn't understand these codes completely and they denied a claim that should not have been denied. And so that is very time consuming, unfortunately. And for those of you with robust coding and billing services, they can help with that. Track which carriers reimburse for which codes as best you can, and then there perhaps is opportunities to negotiate with insurers, particularly those of you if there are any in a private practice model, and share as you learn, please. There are transition of care guidelines available, and these have been updated. And the website is there, the gottransition.org. There's a great clinical report that came out recently about the state of transition of care. And it's a nice read. It gives a nice overview of how things are going really across the country using some of the national data, but also gives a nice roadmap for the things that are important to the transition of care. I'm now going to turn it over to Kathy to go over the nuances of our ICAP training program.
Well, thank you very much, Dr. Caskey. It's a great overview of an introduction to transition. And now we are going to transition a little bit, and I'm going to talk a little bit about ICAP's Transitioning Youth to Adult Healthcare Training Program for Pediatrician Providers. And so this is a program that ICAP has developed along with the University of Illinois at Chicago Division of Specialized Care for Children. And we began working on this back in 2012. ICAP was the recipient of a federal grant, and this grant was through the Department of Health and Human Services, Health Resources and Services Administration, Maternal and Child Health Bureau. And the grant was from 2009 through 2013. And through this, we were able to develop a national training curriculum. And the goal is to target the pediatric providers. That's the one we're talking about right now. So we did establish a lot of experts going back to 2012, and just a few of the contributors here are people like Dr. Miriam Kellichman, who was the lead on the project. She was a neurodevelopmental pediatrician who has since retired. Dr. Caskey, we had Dr. Rossi Folks from the University of Chicago. We had some primary care providers involved, Dr. Tim Gillespie, Mary Teen from Marion Joy was a physiatrist, and several others. So we just included this slide to give you a sample of the different providers and experts who've been working with us on this for several years now. So we've gone through 3 iterations of this curriculum, and we're in the 3rd iteration right now. And so the curriculum has 3 goals. The first goal is to equip pediatricians to provide high-quality, coordinated care for transition-age patients, with a special emphasis on caring for patients with childhood onset conditions. The second is to help practices measure and improve transition care by using the Model for Improvement framework. And the third is to increase the number of transition-age patients that could actually transition to internists or family physicians, and those providers are feeling comfortable and able to accept them as new patients. Again, this curriculum that I'm going to discuss is, while the target audience is pediatricians, there's a wealth of resources that are available for free for all provider types, as well as for patients and families, as well as for social workers and schools. So while the training itself is really intended for pediatricians, all of the resources are available online for free, and that's why if you're not a pediatrician, this talk still pertains to you. And I'm going to show you examples of these resources because we really would like to see them more utilized. We've spent a lot of time and effort in developing them, and our goal is to make them available to everyone who wants to use them for free. And we're able to do that, thank goodness, through our participation in the Illinois Adolescent Health Program grant through the Illinois Department of Public Health. So again, the Heart of the Transition course is for the pediatrician providers. The course was last updated in 2018, and now I'm going to talk a little bit about the key clinical activities that are targeted in this training. The training consists of 11 modules, as well as clinical content, tools, tips, strategies, and many resources, along with ideas for how to change your practice so you can better transition your patients. So this slide shows an example of the tools and resources that are available. The training is online. It's accessible through ICAP's learning management system. And at the end of the presentation, we'll let pediatricians know how to access the training, and we'll let the other participants on the call know how to get a hold of our resources. So the training consists of 11 training modules. It begins with an introduction, and then there's 8 modules that focus on key clinical activities, and those are develop and maintain a registry, develop a written transition policy and share it with your families, develop ways to assess your patient's healthcare skills, help patients create transition goals, provide information on benefits and services, be able to discuss guardianship for patients and families who are going to need support and not be able to independently handle care as they go through transition. Learn how to develop and use a portable medical summary. It's a great tool and a nice way to hand off the patient warmly to an adult provider. And then also help identify adult-oriented providers and build those relationships so that you have a system or, like, let's say, a network in place to facilitate transition. And then there's a whole section on coding and reimbursement, and Rachel discussed a lot of that. But we do go into more depth in the training modules. And then finally, there's a conclusion. Now, along with those key clinical activities, which is really the clinical content that's targeting the pediatricians, as well as their nursing staff who may be working with them hand in hand to implement a transition policy within their office and facilitate transition. We have developed lots of tools and resources for the providers to use and to give to families or patients and families. Social workers, counselors, therapists can go onto our website, which I'll provide the link in a few minutes, and use these resources. You can print them out for free. You don't have to ask for permission. Just please go ahead and use them. And so examples of the things that we have, and I'm going to pull up a few of the documents in a few minutes, but there's a ton of resources, so please go to our website and check them out. We have our routine transition readiness checklist, a caregiver transition readiness checklist. I won't read all of these, but we have a lot of different types of resources. Many of these are available in English and Spanish. The public education resources are all translated into Spanish. And then some of the, we have examples in there of transition policies. So you could look at an existing transition policy and adapt it to your own practice, as well as examples of medical summaries. We have a transition brochure that you could print out and give out to your patients, transition timelines, and so forth. And I'll pull up a few of these documents to look at in just a minute. So along with all of those resources, we do also provide a robust training on the key clinical activities. And this course is approved for continuing medical education credits. It's 15 hours, and it's also approved for 20 MOC Part 4. MOC means Maintenance of Certification Part 4 points for pediatricians. And we've gotten this approved. ICAP applied to the American Board of Pediatrics for the MOC to be counted, and it's approved through 2021 for our current course. And the training around the QI activities are going to focus primarily on helping pediatricians and practices develop a written transition policy and then actually use it and implement it in practice, and measure and document whether or not patients and families have been given the transition policy. The goal is to give it early, around the ages of 12 to 14. In ICAP's case, we start measuring that for patients ages 14 and older. And then along with that, another required QI activity is assessing patients' healthcare skills and their readiness for transition. And we have a checklist that's available as a tool that providers can use in their practice to help document that and measure ability to assess healthcare skills. And then we also have as a measure helping to develop transition goals. So in addition to that, we also have a great resource on adult benefits and services, and we have examples of portable medical summaries and some strategies for identifying adult care providers. So again, this training that I'm discussing with you now is for pediatricians, and it's really helpful for a pediatrician who wants to do this, to do it with their entire practice, because if you're going to develop a transition policy within a practice, you want it to be something that's implemented for all patients, so you want it to be consistent. So, well, let's look at the next slide, please. So the organization of the course is, it takes about 8 hours to go through the CME online training modules, and then there's about 7 hours of QI work that you're going to be doing within your practice to implement the model for improvement and to implement the key clinical activities. And so now I want to just talk a little bit about quality improvement, because we know, like in the healthcare field, QI is the framework that we use to improve the ways care is delivered to patients. We know that processes have characteristics that can be measured, analyzed, improved, and controlled. And QI entails continuous effort so you can achieve stable and predictable results. The goal is to reduce process variation and improve the outcomes of processes for patients and the practice, as well as a whole healthcare organization and system. So our training focuses a lot on QI, and this is part of the requirements that the pediatricians need to meet in order to claim the Part 4 credit. In the U.S., there's been an evolution from quality assurance, which has an emphasis that was more on inspection and punishment for medical errors, to quality improvement, where we're actually looking at what could be done to improve the care that we intend to provide, and how do we know that that care is being provided consistently across the board. So the evolution of QI began in earnest with two landmark Institute of Medicine studies. I know many pediatricians are familiar with these. The first was To Err is Human, Building a Safer Health System in 1999. And then another was Crossing the Quality Chasm, A New Health System for the 21st Century in 2001. Now those progressed and those have built upon things that we use today in practice, which is called the Model for Improvement. So the Model for Improvement and Plan, Do, Study, Act cycles of practice improvement were developed by W. Edwards Deming, and he talks about the science of improvement. And this is actually what is being used now by the Institute of Healthcare Improvement. The American Board of Pediatrics is using that for their QI activities, the American Academy of Pediatrics, the Illinois chapter of the AAP, etc. So our training curriculum builds off of the Model for Improvement. So now we can go to the next slide. So as we get into the QI work, it's important to know that the pediatricians will first participate in phase 1 of the activity, which is doing the 11 online training modules, which adds up to about 8 hours of CME. And then they will move into the quality improvement work if they want to claim the MOC credit. So our course would require pediatricians to participate in collecting baseline data on the 3 required key clinical activities, and then collect follow-up data every 6 weeks over 3 more data cycles. So altogether, it takes about 4.5 months or working on this during cycles every 6 weeks to complete the QI data collection. And we ask the pediatricians to review 10 charts per provider for each activity at baseline, and then 6 weeks later, pull 10 more charts and review the data for the key clinical activities on those patients, and repeat that for 3 more cycles. So that's kind of the dry part of the course, but it's important for pediatricians who are on the phone to understand we are making this available for free. After this presentation, we'll give you our contact information, and you can reach out to ICAP staff, and we can get you, started on the activity. But now going back to something that applies to everybody who's listening, the most important thing that we want to share is our online transition resources. So in the handouts that you're going to be able to download from our presentation, you will have access to our PowerPoint slides, and within there you'll be able to click on the links to find all of these resources that I'm going to point out to you right now. So I want to just give you some examples of resources that you can use today. So the first is the Transitions Checklist for Teens. And so this was a tool that we organized that you can look over, and it's not just for the pediatrician providers, it could be for other types of providers, as well as anybody who's working with a teen or a youth that has special health care needs or doesn't have special health care needs. It's a way to assess where they're at on the spectrum in terms of their transition skills. So this is one example of a transition checklist for teens. And if you can incorporate this into your QI work, or just pick a few of the questions within here and incorporate it into your medical record, or have a way to document that you're looking at these types of transition questions, that it will make it easier for you to, when you pull your patient charts, to document whether or not you have a transition policy and you shared it with the family, whether you are assessing patients' healthcare skills, or whether you've developed transition goals with the patient. This will be one way to help document that. But we also have a transition checklist for parents and caregivers. So when you're working with your patients at earlier ages, there's a checklist you could give to the teen, there's one you could give to the parents. You could say, okay, next year when you come back for health supervision visit, we're going to look at this. and just measure their progress over time to see how they're doing with transition. Another great resource that we have that will be of importance to everybody on the call is the updated, in November of 2018, Guide to Adult Benefits, Services, and Resources. So this is a downloadable pamphlet that contains all types of resources that has to do with healthcare, income support, accessing services for people with developmental disabilities, and then how to access community resources and transportation resources for those that have more complex medical conditions. So it's like it's a 22-page pamphlet, and you can download it and print it out, or just refer to it as needed, or maybe you're just going to provide a link to it and you're going to let your patients know about it, and then they can look through it on their own. We also have a brochure that you can print out that talks about transition issues for adolescents with special needs, with all types of resources that are available around the state. So there's an example of that. Here's an example of a portable medical summary that's available. Again, you can adapt this and you can use it, or if you already have a portable medical summary that you're using, great, continue on with that. Just, we have examples, and you can pick and choose what's most beneficial to you. And then we talked about the QI work. So here's an example of the pediatric data collection tool. So for pediatricians on the phone who would like to take the course, this document will explain further what the requirements are around the QI work and how often you need to pull patient charts and measure what you're doing. We have a learning management system that you can input your patient data into, and that will track your progress over time. ICAP staff will be available to provide technical assistance to pediatricians who are going through the course and who are doing the QI work. So if you have any questions or you're confused or you're not sure how to input your data, we're available to help with that. And then we included a worksheet here on PDSA, what it is, what the key questions are, and what it is. I won't go into it further right now. And then we provided an example of how to write an AIM statement. So, for example, if you're going to work on developing a transition policy and implementing it within your practice, here's an example of how you would do it, and the AIM statement has already been developed. So you can see that we try to make this as easy as possible with a lot of resources and help available. We also provide examples of written transition policies. So this example here was developed by North Arlington Pediatrics. This was one of the pilot sites that we worked with when we developed the training curriculum, and over time they developed their own transition policy, and this is what their current policy looks like. Here's another example of a policy from a family medicine clinic. Okay. So those are just great examples of resources that we have and that are highlights. Again, all of these resources and many others can be accessed here by clicking on the links within these slides. And in addition to that, God Transition, which is a national organization, has really great resources. So you please go ahead and look at what they have as well as what the national AAP has. So I just went over the most popular resources, again, as a reminder, the course is available for pediatricians who want to bring other providers, pediatricians into their practice can do so, and you can also bring nursing into it, and they can claim CME credit if they wish to participate in the training modules. And also if they're going to help out with the QI work. There's many other documents that I won't go into, but we have like barriers and ideas for change grids and so on and so forth. So now I'm just going to quickly mention that the course itself has been pilot tested, and we worked with 5 practices that tested it out, targeting patients 14 years and older, and we tested them out during June to December of 2012. We collected data from practices, so we had a wide variety of practices. We had an FQHC, we had a primary care practice, an adolescent practice, and 2 other practices that participated. In total, we had 35 pediatric providers. All of them tested out our key clinical activities, and they determined that the project tools are effective. We also had youth and parent partners involved in the development of our tools. And we've also been working hand in hand with the Division of Specialized Care for Children in the development of all of these tools. Here's an example of a health system that had 2 centers that went through the training, and they had their pediatric providers as well as their adult medicine providers go through trainings. And they implemented it across their practices. And so this is just an example of a slide that shows what the data would look like as you get into the QI work. So if you look at provide and explain the written transition policy, you can see a baseline for the 4 providers listed. It was 0 because they didn't even have a transition policy. So one of their first activities was to develop that. And then it was to implement it and hand it out to patients and families of patients 14 and older for this activity. And you can see over the cycles 1, 2, and 3, the improvements that were made. And then we do have target goals. So for developing and implementing the transition policy, the target goal is by the end of the QI period to achieve 90%. And for assessing healthcare skills, the target goal is 70%, as an example. And all of this is explained in the QI tools. So as a quick summary, this is a web-based training. It's CME approved. Pediatric providers can get 20 MOC Part 4 points if they do the QI work. All the tools and resources are free, so anybody on the call can access these. We encourage you to do so. The materials have all been pilot tested, and it's available nationally. So we're making this available in 2019 for free to Illinois pediatricians, but it's available to pediatricians across the country. So we do have pediatricians who are in the course right now, and we're able to look and follow along and see how the doctors are doing, not only at the individual level, but at the aggregate level. So when we're providing information on your progress, we'll be able to provide data on how you compare with your peers, which is also very helpful. So at this point, I was going to ask Dr. Caskey if there's anything that she would want to add, and then we'll open it up for questions.
Thank you. No, I think I just want to echo that it really is a wonderful course for both CME as well as MOC, and a great opportunity for individuals or practices to look at their transition planning. And it walks you through all the steps. So I just want to echo that.
Great. So at this point, I'm going to turn it over to Olivia. She's going to, if there's any questions, she'll field those for us, and she'll be able to close out the presentation.
Thank you for joining us. This is just a couple things to wrap up the presentation. Just this past October, there was the Illinois Statewide Transitions Conference sponsored by DSCC, and that was held in Itasca. And so this year, the conference will then be October 17th through the 18th at the Gateway Center in Collegeville, Illinois. And again, it'll talk about transitioning youth to adult health care, which is very pertinent.
Yeah, and I just want to add, for those of you who are not familiar with this conference, it's in 2018, they brought back a health track. So, and they're going to do this for 2019. So there's an opportunity for a day of providers to be able to go and get CME and get a lot of training. But they're also related to transition, but they're also going to be able to have access to resources that have to do with employment options for people with disabilities, assistance with transitioning youth into and using community-based resources, and many other very helpful tools. So this is going to target the schools, it's going to target the providers and the community, and it also is an opportunity for patients and families who are going through transition to also participate.
Any questions that you may have about the training curriculum or registering, please contact me again, Olivia, at ophillips@illinoisaap.com, and also my number is listed as well. And so thank you for joining us again for this webinar. This is again the first of a 5-part webinar series in our Adolescent Health Provider Health Education Initiative. And the next webinar will be on teen brain development, the effects on health and human behavior, or effects on health and behavior. It'll take place February 22nd from 12 to 1 p.m. And again, registration is open, and also a flyer for this upcoming webinar is listed in the handout section, as well as the save the date flyer with registration links and dates for the other webinars upcoming in the series. So we'd like to thank you again. I don't see any questions at the moment, so if you're a little shy, please feel free to send me an email, reach out to us, and we can answer any questions that you may have regarding the training or tools or registering for the course.
And then I would also like to say, for pediatricians who are interested in this, the best way to get started is to reach out to Olivia or myself, because we have a resource folder that we will send to you by snail mail with examples of all the resources, the QI tools. So you can look through the folder and just make yourself, get comfortable. And most importantly, be aware of all the great resources that are available that you can pick and choose from and decide what you want to use or give to your families and patients. And then from there, you can move right into the online CME training module. And then after that, you'll start doing the QI work, and then we'll be able to provide technical assistance along the way if you have questions.
And so thank you again for joining us. Just a reminder that this webinar will be posted on our website at illinoisaap.org, and it will be on the front page, so you will be able to see it and click there, and then you can listen to the recording. So thank you.